we are going to go through an entire case where, this is a case that has come today morning, who has vomiting, is a 61-year-old female who is coming with vomiting for 2 to 3 episodes after all meals with very severe weakness. And she has diabetes, is what it's mentioned over here, that she does have diabetes, okay, and she's been on glycinom M5500, Vilda M5500 and Invokana 100 milligrams, half 00. Also she's been on insulin, and she's presented to us with a pulse rate of 100, BP of 100/60. The chest was clear on admission and there was a profile on screening. But when they did the sugars, they found the sugars to be very, very high. Okay, so a baseline blood gas was also done, and we have the baseline blood gas here. I'll show the blood gas. So the baseline blood gas shows a pH of 6.863, a PCO2 of 10, a PO2 of 147, a bicarbonate of where is the bicarbonate? 4.2, and the actual bicarbonate was 1.7. Sodium is 130. Calcium is 5.14 and potassium is 5.3. There's a glucose of 768, lactate of 2.5. Now in a patient who comes in with a sugar of so high amount along with acidosis, the first thing on a background of diabetes you should always think is diabetic ketoacidosis. And the other thing you can think of is because she has this episode of vomiting and she's old, there's a possibility she was not attended to. The other thing is hyperosmolar non-ketotic coma. Now since that is non-ketotic, the only thing you can do in these cases is to actually figure out ketone bodies. So they've done the ketone bodies here, and when there is the ketone bodies, they found the ketone bodies to be 4+. So now if I put all of these things together, there is a 4+ ketone bodies. Okay, there is a acidosis that shows pH of 6.863, and you have a HGT that is 768. Okay, this is what we have. Now, when you say ketone, so this clearly, is a case of diabetic ketoacidosis. Now, what's exactly happening? Since you're here in this bed, right? So the first thing that they found is ketone bodies, right? Ketone bodies. There are 4 ketone bodies. So what are ketone bodies actually? There are 3 types of ketone bodies. What are the 3 types? Yeah, sister. So it's beta hydroxybutyrate. Beta hydroxybutyrate. And you have to remember this. If you don't know this, it's problematic. There is acetoacetate, and there is acetone. These are the 3 ketone bodies. Somebody asks you what are ketone bodies? These are ketone bodies. Okay. Now, ideally, what you should have insulin going inside the body and glucose getting into the cell. This is not occurring. Since that is not occurring, the energy is coming from the fatty acids. Free fatty acids are getting released, and those free fatty acids are getting converted to beta hydroxybutyrate, acetoacetate, and acetone. Okay, and once the renal system is unable to handle this load, that is when it starts getting into the urinary tract. Clear on this? Again, I'll repeat it. Normally, what is happening? Glucose is there in our body. Insulin works on this. Glucose gets inside. That's how it normally works. Now, what is happening over here? This is not occurring. Okay, because there is a lack of insulin or whatever is happening over here. It causes the release of all of the counter-regulatory hormones like glucagon, catecholamines, cortisol, all of these things, because that insulin is not there. So glucagon, cortisol, and catecholamines. These are the 3 things that happen in these cases. Whenever these 3 things happen in these release, okay, there is going to be that pulse rate going up, the BP going on the lower side. All of these things are occurring because of all of these things. Okay, but what happens is the free fatty acids, which were it is supposed to suppress the lipolysis. Insulin is supposed to suppress. Insulin not only does work of glucose, it also does the work of suppressing lipolysis. Okay, suppressing lipolysis is another thing that it does. Lipolysis. Okay, so it has to suppress this lipolysis. So since it's not suppressing this lipolysis, the free fatty acids are releasing, which gets converted to beta hydroxybutyrate, acetoacetate, and acetone. So the amount that is coming out from the free fatty acids is so high that it supersedes the renal system, and that's why you start seeing urine. Urine में beta hydroxy, you see urine ketone bodies that comes positive. Now, importantly, what you should understand once you're doing the uroketostics test is the fact that when you're doing the uroketostics or urine ketones, it normally doesn't see these 3. It sees acetoacetate. It doesn't see the main thing. The main thing is beta hydroxybutyrate. The beta hydroxybutyrate is the most important ketone body. So you may underestimate a diabetic ketoacidosis if you were to just believe on a urine ketone sticks. Also, you must understand is because what is going to happen over a period of time, if the beta hydroxybutyrate is a very high amount, it will slowly convert to acetoacetate. So, if the patient is improving also, say the patient is improving, you will still find ketone bodies positive. Because what is happening, this beta hydroxybutyrate which was there is now getting converted to acetoacetate, which is now being picked up by ketone bodies. Are you getting the point? Huh? You're going to pick up ketone bodies. That's why the ketone bodies keeps coming positive. So you cannot, what I'm trying to tell you, ketone test cannot be used to prognosticate. It cannot be used to figure out whether whether the patient is coming out of DKA. It cannot be done because it's just converting. It's just converting. You're understanding? You just can do a ketones to understand, okay, ketones are positive. So what do? You normally want to do the serum bicarbonates, serum beta hydroxybutyrate. So when the serum beta hydroxybutyrate is more than 3, we call that to be very high ketone bodies. If it is less than 0.6, we say it's coming out of DKA. So if you want to know whether it's coming out of DKA and you want to use ketones as the agent, because you know very well that if insulin starts off and the patient redox gets better and all the anti-metabolic milieu gets better, this is going to stop. Insulin free fatty acid suppression, that will start again. You understand?
Yes.
Because when this starts again, the suppression will start again, ketone body production will reduce. That means to say DKA is coming down. So if you want to do from ketone bodies, you need to repeat beta hydroxybutyrate and see whether it's coming less than 0.6. Okay? Clear on this? Understood about ketone bodies here?
Yes.
Okay. Now let's dissect this blood gas here. Now this blood gas shows pH of 6.863. And at the same time you have the PCO2 that is less going low. Once this is the situation, we know the problem is metabolic. Okay, we know the problem is metabolic, and since the pH is going down, this will be called as metabolic acidosis. Okay, the expected compensation for PCO2 in such cases is 1.5 into bicarbonate. Let's say the bicarbonate is 4.2 plus 8 plus or minus 2. Now what is 1.5 into 4.2? 1.5 into 4.2? 6.3 plus 8 is how much?
The C is 14.
14. So 14.3. So it can be 12 to 16. This is what it is. Now what is the PCO2 here? Expected PCO2 is 10. What does this mean? That not only does he having a metabolic acidosis, he is also having a uncompensated respiratory alkalosis. You understand, no? Ideally your PCO2 should have been 12 to 16. You are having a PCO2 of 10, which indicates that it is not compensating that well. So it has he has on top of it, patient has got a respiratory alkalosis. So metabolic acidosis with respiratory alkalosis is what this patient has. Clear? This is one part of the story. The other part of the story you see over here is that you see a sodium level that is 130. Is this normal? What is it? Huh?
130, 120, yeah. It is normal.
What is normal range here? Okay,
137.
So 135 is normal. So is this normal or not?
No, it's slightly low.
Slightly low. So you want to give 3% saline here?
No,
Why?
because
She was drowsy when she came in. So what you should understand here is how to interpret the sodium here. So remember this, for every 100 milligram DL, over 100, there will be an increase of 2.4 of sodium when you look at sugars. So here it is 786, 768. Okay, 768 minus 100 is 668.
yes.
Correct? 6.68, that is every 100 is 6.
6.
So somewhere, no?
Yes.
So now 130 plus 6.68. 130 plus 2.4 into 6.68. How much is that?
146.
146. So he is not. He is in fact more. So there is hyperosmolar state here. Now to find out whether it is hyperosmolar, what do I need to do? 2 into sodium plus glucose upon 18. Isn't it? Now your corrected sodium is 146. So 2 into 146 is how much?
292.
292 plus glucose, that is 768 divided by 18. What is 760 divided by 18?
760 divided by 18 comes to 42.6.
42, right? So when I add this now 4, 13, this becomes 334. Now once this is 334, what does this mean? It is hyperosmolar. You understood this working or no? Should I repeat it? You want to repeat it? So let's repeat this once again. Okay? So let's repeat this again. So please understand this. This is very important that you understand what you are dealing with. Okay? If you don't understand, you must stop me and ask me again. Okay, let's go again. So So I'm going to this blood gas again. In the blood gas, we initially, I'll repeat the whole blood gas for you. So 6.8 is going down, PCO2 is going down. That means the primary disorder is metabolic. And since the directional change is downwards, so it is acidosis. The expected, the correction here would be PCO2, compensation. So the expected PCO2 is going to be 1.5, the formula is 1.5 into bicarbonate plus 8 plus or minus 2. When you put this, plug this into this bicarbonate formula, which you see bicarbonate is 4.2 here, plus 8 plus or minus 2, your answer comes as 14, means 12 to 16. But what we are seeing observed is equal to 10, which means there is superadded, you can call it superadded respiratory alkalosis. So there is metabolic acidosis plus superadded respiratory alkalosis with high anion gap. Why is there high anion gap? Because it is 35.5 because of high anion gap. Okay? So there is metabolic acidosis with high anion gap, with respiratory alkalosis. Clear on this? Clear on this ABG?
Yes.
Okay. Now the entire question is, okay, now what about my sodium? My sodium is showing as 130. Now what we know here is that for every 100 milligram per dl, above 100, you have to add 2.4 of sodium. Okay. So every 100. So 768 every 100 is 668. So 668. So 6.68 हो गया. So 6.68 into 2.4. Will make it how much? 16. So that means you are actually 146. Clear on this much? So this sodium that you're seeing over here is not, this is not normal. The true sodium is 146. Okay. Now it's 146. What is my osmolarity? So 2 into sodium plus glucose upon 18 is osmolarity, which means 2 into 146 plus 768 divided by 18. Glucose upon 18. What is the answer here? The answer is 334. So this is hyperosmolar. So this is not just a simple DKA. This is a DKA plus hyperosmolar state. Okay. Now what we see on blood gas 1 versus blood gas 2. Let's just remove the blood gases. Where the blood gas is 1? ये blood gas इधर है. Below the file. Now let's go on and see what has happened here. Okay. Now this patient, obviously the first treatment of choice here would be give fluids. The first thing will be give fluids. So when you give fluids, so we have to figure out DKA plus hyperosmolar state. Both are there here. Now what we also see in this blood gas is the presence of a lactate. Now the lactate is 2.5. Lactate is 2.5, which is high. 1.7 तक हमारा normal होता है. So it's 2.5. It's on the higher side. Lactate is high. And what has happened is now you have repeated blood gas after the resuscitation. Now after this blood gas, and this is what your blood gas has: 7.2, 4, 4, 15. Now let's again do the calculation. So pH is going down. That is 7.2. PCO2 is going down, which is 15.2. So it is primary disorder is metabolic. The direction is downward, so acidosis. So expected PCO2 is 1.5 into bicarbonate. Let's see the bicarbonate 9.8. Plus 8 plus or minus 2. What is 1.5 into 9.8? 14.7 plus 8 is how much?
22.
So it is 20 to 24. This is the expected PCO2. Expected PCO2. We are expecting PCO2 20 to 24. What you are seeing is 15. So she still has metabolic acidosis plus superadded respiratory alkalosis. This is clear now? This is clear? Now what you are also seeing here is the sodium. Sodium is 142. Now sodium is 142, but here what is the sugar? Still it is 747. So what has happened here? Sodium is 142. Okay. Now you add that 6 point. It's still 6 times, no? So let's take that same value. 6 point. What is that? 6.68. So 2.4 into 6.68. 6.47 हो जाएगा ये. 6.47 कितना आ गया ये? Because 747 ना. 747. So 6.47. How much is this?
15.
So it is 142 plus 15, which means
157.
167. Sorry, 157. 157. So this seemingly normal sodium now becomes very high sodium here. Because very high sodium here. Now what is the osmolarity here? 2 into sodium plus glucose upon 18. Now look at 2 into sodium. What is 2 into sodium?
314.
Is 314 plus glucose is 747 divided by 18.
It's 41.
So it is 314 plus 41, which is
355.
so now the osmolarity has gone even more higher. Now why has this occurred? This has occurred because most probably somebody has given bicarbonate here. Or given sodium rich fluid here. Okay, similarly bicarbonate. So someone has given sodium bicarbonate here, which has actually caused, he might be wondering, or he or she might be wondering, sodium has become 142. But it is not 142. The actual sodium is 157, and that is the reason that she's a little bit down and neurologically not okay. So this has actually gone up. So he's hyperosmolar state now. This is because of because of sodium bicarbonate. Somebody would have seen this 6.86 given that sodium bicarbonate. This is what would have occurred here rather than just resuscitating. But that's not my only concern. My concern is why is the lactate gone from 2.5 to 5.7? If you have resuscitated, of course, he's resuscitated this patient. If you have resuscitated this patient, this shouldn't have occurred if you have corrected perfusion. This shouldn't have occurred if you have corrected perfusion. We are seeing the lactate going from 2.5 to 5.7. So why would this occur? Question is that. Okay, this can occur because of either sepsis, but then there is no history of fever, there is no history of any abdominal issue, there is no respiratory issue, there is nothing happening over here. So this doesn't look like it. There is a WBC count on the higher side. It shows 24.6. But normally diabetic ketoacidosis patients will have high WBC counts. Neutrophilic leukocytosis do occur in patients who have diabetic ketoacidosis. That doesn't mean there is an infection there. Her BP is now still on the lower side. We cannot rule it out. So we'll have to figure out what is happening here. So definitely we'll send a CRP. We may send a PCT. And we may look at all sources of infection here. Okay. Now the other thing that can cause it, if you remember, she was on 2 drugs. She was on a drug called as metformin. Okay. Now metformin per se is known to cause lactic acidosis. It's called lactic acidosis. So there is a situation that this patient is on metformin, which is contributing to this lactate going up. Okay. So when you have this is called as metabolic acidosis, metformin associated lactic acidosis, also called as MALA. It's also called as MALA. Metformin itself can cause lactic acidosis. But then this, if it is metabolic associated lactic acidosis, the treatment of that usually is if the pH is less than 7.1 or if the bicarbonates are less than 15 is actually to dialyze. But we are saying this is not the only thing. For example, if you have a patient that is coming in from outside with metformin toxicity, not like DKA, not like DKA, and you have a history of having metformin being taken 5 or 6 tablets or 7 or 8 tablets, and then you find this picture, then the treatment and the pH would have been 7.115. The treatment would have been HD. And this comes from a trial called as X-Trip. The trial called X-Trip. It comes from that trial, X-Trip trial that says if the metformin is less than 7.1, I mean the pH less than 7.1, bicarbonate less than 15, I would want to go for hemodialysis. You get the point? So the lactic acidosis here could be contributing from metformin. It's not the cause. It's not the cause. You're understanding? Now the other issue that you also have is SGLT2. Here she has got SGLT2 inhibitors here. Now SGLT2 inhibitors, what is the problem? What is the problem with SGLT2? Sorry? So what will happen with that? What will happen with that?
Chances of UTI, urine infection.
So let's take it on a logical sense. What is going to happen? You have put the patient on SGLT2 inhibitors. Now what is going to happen? Because there is glucosuria, the body starts wondering कि मेरे पास glucose कम जा रहा है. So it will try to shut off the insulin. So if it shuts off the insulin, what can occur? Free fatty acids will not be suppressed. It will form ketones. So you will have paradoxically the glucose being normal. Okay, in such cases, if it was just SGLT2 inhibitor, the glucose will be normal, but the ketone bodies will be positive. This is called as euglycemic diabetic ketoacidosis. This is called as euglycemic diabetic ketoacidosis. So here, partly in this case, the ketone bodies could also be coming from the SGLT2. Partly, getting the point. So in this case, what am I saying? Is this patient improving? Initially I was told patient is improving. Patient is not improving here. In fact, patient is worsening here. No? If you look at it, lactate is worsening. What is a picture that says patient is worsening further? Anion gap. Look at the anion gap. The anion gap is 35. It has increased to 40. So if the anion gap has increased from 35 to 40, what is anion gap after all? Anion gap is sodium minus chloride plus bicarbonate. This is what is anion gap. This means to say that this fraction, this sodium fraction is going higher and higher. That means anion gap is widening. Ideally what you should have had, the anion gap should have got narrower. So when I say blood DKA is improving, I am not looking at urine ketones getting out of the body. What am I looking at? I am looking at pH correction. I am looking at sugars going down by 50 milligram per DL every hour. 50, at least it should be 50 milligram per DL every hour, not faster than that. Okay, 50 milligram per every hour. So and third thing I am looking at is anion gap closing and bicarbonate becoming normal. So here we have the bicarbonate getting normal. Okay, it is not getting normal. I mean, it's not at all getting normal. It has remained rather the same only. Hardly it has moved. Anion gap is not moved. The only thing that has changed is the pH. So is this recovering? No. In fact, what has happened is become hyperosmolar. So here the soda bicarbonate has caused the issue. Probably you should have increased the fluids further. Okay, so we came in the morning and we did increase the fluids here. Where is the new blood gas? So the blood gas.
This
So then what happens next? So what happens next is you are at what is now blood gas, okay, in the morning. So let's see the morning blood gas. So let's go back to the same cycle that we're doing. Okay. So what we see here is the pH has further improved. The anion gap has started closing. It was 35, it has come 27. So anion gap is closing. The bicarbonates have started going up without bicarbonate. So bicarbonates are going up without bicarbonate. So now this indicates, and the lactates are coming down to 2, indicates that the DKA is getting better. But then where are we now? So pH is 7.4. PCO2 is 23. So you have come to a mixed situation here, which indicates that there is an improvement in diabetic ketoacidosis. Getting the point? So what is the next step here? What the problem is over here is, what is the problem over here? Sugars are come down to 230. So what do we do?
We can start little glucose also in the drip.
Do we? Why you want to give glucose?
Because insulin will be continuing. So
Why you want to continue insulin?
Potassium.
Why do you want to continue insulin? In
Because
this
it
case,
suddenly
in
stops
DKA,
when-
sugar is now the sugar is 230. Why do you want to continue the insulin?
Suppresses the lipolysis.
Correct. Correct. So the problem is not this. No problem is the creation of beta hydroxybutyrate, acetoacetate, and acetone. And this is coming from where? This is coming because insulin is not there. Because insulin is not there, there is a release of glucagon, there is a release of cortisol, there is a release of catecholamines. This per se in turn along with this causes suppression supposed to cause suppression of lipolysis. This is not occurring. Hepatic ketogenesis is not is continuing. Since hepatic ketogenesis is continuing, suppression of lipolysis is not happening, there is a contribution to the ketone bodies. That is why I cannot stop the insulin. You understand? I may reduce the insulin, but I will not stop it. Other way around, let's take this was not improving. Even after my fluid resuscitation, then I would be increasing the insulin. You know, because it is the ketone bodies that is causing the problem. So the usual rate of insulin is 0. units per kilogram per hour. This is what you start at. And then say now you feel that okay, this is the situation has come in, I have resuscitated my patient. The next thing will be I'll continue the insulin, and to ensure that there is no hypoglycemia, I will start sugar. That is dextrose. The reason to start dextrose, you understood now? The reason of dextrose is I have kept the insulin, I need the insulin to be on because the pathophysiology demands it. You understand? So I will keep doing it till my beta hydroxybutyrate goes less than 0.6. You're getting the point? Now, since if you're not going to do serum beta hydroxybutyrate, I will look at these factors. When they become normalized, for example, here it is getting normalized but not normal yet. The bicarbonates are still 20, let it reach 24, let the pH get even more better, let she be okay all the time. So she is getting normal, no doubt. Anion gap is closing, anion gap is not yet closed. You understand? Let the anion gap close down to 12. This anion gap is contributed by the ketones. It is contributed by the ketones here. So once the anion gap starts closing downwards, this patient can be weaned off that insulin. You getting the point?
Yes.
Meanwhile, what is the biggest thing that you should think of in this case? It's going to be massive arrhythmia. And why will that
Yeah.
occur? Because
Potassium.
literally you are giving a GI drip.
Potassium.
Literally you are giving a GI drip because there is dextrose in the body and you are giving insulin. So this becomes GI drip.
Yeah.
So when there is GI drip, potassium will just run inside. So what is the mistake done in this case? It was not started.
Yeah, potassium should be given
Aggressively, right from starting. Once you reach 5.5, you start giving potassium. Once you reach 5.5, you start giving 30 cc, others will become very difficult for you to take care of it. समझ में आ रहा है? So once you reach 5.5, you start giving potassium. Once you reach 250, you start giving dextrose.
Yeah.
Once you reach 250, you start giving dextrose because I want to keep the insulin on. You understand? So once you reach 250, I start the dextrose. Once you reach potassium 5.5, I start the potassium. What about phosphorus? So because of all this, phosphorus also goes haywire. But there is nothing to suggest I want to give phosphorus. There is nothing to suggest. For example, here, you look at the phosphorus over here. The phosphorus is shown as 4.7. The only place in DKA where I will change this phosphorus is when the phosphorus is less than 1. I will chase it only when the phosphorus is less than 1. I will not chase it at this level. 4.7 is kind of normal. You getting the point? Simple? Any other queries on this DKA? You've understood this?
Yes.
Go ahead.
So, like you said, that lactate increase in lactates, that can be because of the metformin, and she was on SGLT2. So, if it is caused by metformin,
No, it is not caused, contributed. If it was caused, means क्या होता है? You have taken 15 tablets of metformin and come to you in a suicide attempt. For example, or it's like toxicity. For example, you've taken 4 when you are not eaten any food and some kind of metformin. You are getting the point. That is when it happens where the pH will go down. It will not be diabetic also. Urine ketones will be negative there. Urine ketones will be negative there. You will get a picture where there is severe acidosis. You will get a picture where the bicarbonates will be on the lower side, but there will be no urine ketones. You are getting the point.
Right.
Since there is no urine ketones, now we know ketones have to come in, or serum ketones are not going up. It will be metformin associated lactic acidosis. You will find the lactates to be high. You get the point. Essentially, lactates are more than 15, more than 20 in those cases. Essentially, lactates are more than 15, more than 20. So when the lactates are more than 15 or more than 20, pH is on the lower side. That is called as metformin associated lactic acidosis. That is the time you go and dialyze. Now here it is maybe contributing. Why am I telling you it's contributing? Because of the fact that I can't explain the lactate otherwise. So it's contributing to that. And as time is going, metformin is getting out of the body, and that is why it's getting better. Notice it's getting better because metformin is getting out of the body. So what are the mistakes in this case? In this case, mistake is first, here no bicarbonate shouldn't have given. Though you may be justified for that time part being when there is extreme acidosis, maybe 50 cc, you might be justified there because you are thinking maybe the heart is going down or things like that. That's a different situation. But if the heart is okay, otherwise okay, the answer should have been just fluids here. What is the other issue after bicarbonate is reduction in the amount of fluid. You should never have reduced the fluids over here. You should have just continue the fluids because what has happened because of that, hyperosmolar state has developed. There is hyperosmolar state that is developed. That's why the sodium that you're seeing over here is what actually normal. But because you dehydrated the patient, now it has become 157. Though it is 142 here, it has become 157. Third mistake, we should have started insulin, you should have started potassium right away.
That's why I have a question. Because ideally they say, right, like after getting 1.5 liter, you start adding potassium.
You just add, so the answer is to add potassium in every pint. 5 cc, 5 cc, 5 cc in all the product. But ideally, if the central line, it becomes easier. But that's the reason that here only you should have added potassium. Now the chase of the potassium becomes rather difficult. Now you will keep on giving. Now at this moment the potassium is 2.8 or something. So this means to say very difficult to actually chase because this is the time when we should have done it. So here we will start 30, 30, 30. You imagine 50 difference, 50 how many backwards we are now. So it's going to take a long time before that potassium actually gets into the system and the arrhythmia. The big issue is because of all this arrhythmia. Then also you have understood how to calculate sodiums in these cases. You have understood that. Again I'll remind you 100 milligrams above 100 is 2.4. Above this. समझ में आ रहा है? Is 2.4. Addition of 2.4. समझ में आ रहा है ना? Any other queries here?
And then the fourth is a dextrose we should start.
So the cutoff I said is 250. 250 for dextrose.
Only dextrose, plain dextrose.
DNS, you can start DNS depending on what you are doing.
In this case, DNS will not be
correct. In this
feasible.
case, be 5% dextrose.
Because I think we've started DNS. I think I'll just.
You'll have to change
that
all
also
the
is a
things.
mistake. I'll have to change it all. Yes, yes.
ठीक है? हाँ?
Yes.
ठीक है. All right.